Good morning, everyone. So, continuing our series of primary neoplasms of the pleura, today I'll be doing a brief overview of malignant pleural mesothelioma. So, malignant mesothelioma arises from the mesothelial surface of the pleural cavity, peritoneal cavity, tunica vaginalis or pericardium, whereas pleura is the most common site of this disease, and it is mostly most commonly observed in the Western countries, like USA, Western Europe, and Australia, where they have a high, they have a history of use of asbestos in the community. Mesothelioma is actually very less common in Nepal, and we have done a series in our center. We have done a series of biopsy for pleural lesions, where out of 85 cases, only one case was malignant mesothelioma. So it is the 32nd most common cancer in Nepal, with a yearly incidence of 0.04% of all cancers. So coming to risk factors, the most important risk factor for malignant mesothelioma is asbestos. So asbestos is the commercial name of a group of hydrated magnesium silicate fibrous minerals. These are long. When you see these minerals under the microscope, we see there are long fibers, like fiber-like structures of these minerals. They are commonly the various types, most common being the chrysolite, anosite, crocodile, crocodolite, etc. And asbestos occurs naturally in the soil and rock as long fibers, and they are usually used in the industry for its resistance to heat and combustion. So it is used commercially in cement industries, sealing, and pool tiles, and in automobile brake linings. The latent period for exposure to asbestos and development of mesothelioma is around 30 to 40 years. So, how does asbestos cause cancer in the mesothelial cells? So, because asbestos is an inert fiber structure. So, when inhaled through the during respiration, the asbestos migrates through the lung parenchyma into the pleura. In the pleura, the asbestos causes necrosis of the mesothelial cells. It has been shown that in vitro, almost all of the mesothelial cells undergo necrosis after contact with the asbestos materials. And necrosis of the mesothelial cells results in release of the HMGB1 enzyme, which causes inflammatory response by releasing the reactive oxygen species, recruiting macrophages and immune cells. So this results in a milieu of chronic inflammation in the mesothelium, and over a prolonged period of time, this results in mesothelial cell transformation to the malignancy. Although asbestosis is the most common cause of malignant mesothelioma, accounting for almost all the cases, there are other risk factors as well. One of which is radiation. Ionizing radiation to the supradiaphragmatic field, that is to the mesothelial lining of the pleura, is also a risk factor for developing mesothelioma in the future. In regards to difference with the asbestosis, while asbestosis develops over a period of 30 to 40 years after exposure, the radiation, the patients with radiation, they are usually younger, and it usually develops around 20 to 30 years after exposure to the radiation. And this is most common in patients who are treated with thoracic irradiation, mostly for patients with lymphoma, and in rare cases other cancers such as breast cancer and others. And there is a viral oncogene called the simian virus 40, which is a polyoma virus, and it has been shown to have oncogenic potential in vitro. and there was a incidence of contamination of oral polio vaccine with SV40 in the 1970s, and this has also been theorized to have oncogenic potential. So there are some genetic factors, and it has been found that some mesothelioma cluster in few families, and it has also been shown that some people have a greater chance of developing mesothelioma when exposed to asbestos as compared to other patients. So studies of these genetic factors have identified the BAP1, which is BRCA1 associated protein 1, and it has been identified as having increased risk of mesothelioma. Uh, the germline mutations of BAP1 has also been identified as a positive agent for mesothelioma, and it has also been shown that up to 60% of mesotheliomas have some sort of somatic mutation of BAP1. Other less frequently appearing genes that have been implicated in mesothelioma are BLM, BRCA1, BRCA2, and others. So coming to classification, the 2021 WHO classification has been shown in the slide, and here you can see the mesothelial tumors are divided into either benign, which contain the adenomatous tumor, the well-differentiated papillary mesothelial tumor, which was previously known as differentiated papillary mesothelioma and mesothelioma in situ. Whereas previously mesothelioma, it was called as malignant mesothelioma. The term malignant has been dropped, and it is only mesothelioma now, and it is divided into either localized or diffuse mesothelioma. And diffuse mesothelioma is divided into three types: the sarcomatoid, epithelioid type, and the biphasic type. So coming to clinical presentation, this tumor develops over a period of many years. The latent time from exposure from asbestosis to development of malignant mesothelioma is 30 to 40 years. And over this period of time, because of the presence of asbestos, the patient develops other chronic respiratory symptoms as well. So these include chest pain, dyspnea, cough, hoarseness, night sweats, or dysphagia. Although distant metastases rarely present in the initial setting, the patients, it has been found in autopsy series that up to 55% of patients with malignant mesothelioma have distant metastasis. And the distant metastasis is usually involves the bone, liver, and CNS. Systemic symptoms such as fatigue and weight loss may also present if the disease burden is high. The age is usually in the older age group. Usually the disease presents after 60 years of age. Very rarely, patients with malignant mesothelioma may present in an acute setting with involvement of the brachial plexus or compression of the spinal cord due to the bulk of the disease. And very rarely, because of direct diaphragmatic involvement, extension of the mesothelioma into the peritoneal cavity the patient may present with small bowel obstruction. So signs that we see in the clinic in patients with mesothelioma is due to the presence of pleural effusion. So these include unilateral dullness to percussion, decreased air movement on the side of involvement, and asymmetric chest wall expansion. So coming to imaging, CCT chest is the standard imaging of choice, and here the findings may include a unilateral pleural abnormality with large pleural effusion, or a pleural mass or diffuse pleural thickening without pleural effusion, and there may be pleural plaques or calcification which represent the deposits of asbestos, and there may be ipsilateral mediastinal shift due to encasement of the lung by the thick rind of tumor and the ipsilateral lung volume loss. So let's go through some pictures. This is a chest X-ray showing a progressive malignant mesothelioma in the same patient. So the first picture is a unilateral baseline left-sided pleural effusion, and the second picture is the same patient after 3 months of time, where there is diffuse pleural involvement in the ipsilateral side, and we can see some pleural masses like this. Coming to the third picture, this is around 5 months, and we can see that the entire hemithorax has begun to be involved, and there is loss of the lung volume as well. And this is the fourth picture, and after around 8 months, the entire left hemidiaphragm hemithorax has been involved, and there is also involvement of the contralateral uh, hemithorax. So this is the classical picture how a mesothelioma may present in the chest X-ray. This was a reactive lesion. So this is another picture showing the right-sided circumferential pleural thickening, and here we can see that there is extension of the mesothelioma into the major fissure, and also extension into the recess between the esophagus and the azygous vein. So this is another picture of mesothelioma showing pleural effusion with calcified plaques. These plaques represent the deposits of asbestos. So besides CT scan, other imaging modalities include the MRI. MRI is useful in delineating the invasion into the vital structures such as the heart, blood vessels, the pericardium, and extension into the diaphragm. Or invasion of the chest wall. We can see the mesothelioma extending into the major fissure, and here involving the diaphragm. Besides this, other imaging modalities that can be used is the PET-CT scan. The PET-CT scan is useful in differentiating whether the effusion is malignant or not. So to differentiate between the benign mesothelial proliferation versus malignant mesothelioma, PET-CT can be used. Also, it can be used to see if there are distant metastases or if there is involvement of the lymph nodes. So, how do we diagnose malignant mesothelioma? The initial evaluation in patients who we suspect with malignant mesothelioma with either a chest X-ray or the patient's presentation, we have to do the contrast enhanced CT of the chest. Following this, because most of the symptoms are because of the pleural effusion, a thoracocentesis will first of all, it will lead to symptomatic improvement, and also may provide us the samples for microscopy evaluation. So either doing a cytology or creation of the cell block to see if there are any malignant cells can be done. And if we suspect that there is a malignant mesothelioma, then a closed pleural biopsy, either USG or CT guided biopsy of the pleural thickening can be done, and some studies have found that it has up to 85% sensitivity in diagnosing malignant mesothelioma. But the gold standard for diagnosis of malignant mesothelioma is surgical biopsy, either via VATS or open thoracotomy. And this gives us a chance to see the entire pleural cavity, and even if there is some localized mesothelioma, we can sample that tissue to obtain the biopsy. So the indications of VATS for malignant mesothelioma is those with large effusion or those who have negative studies on thoracocentesis and pleural biopsy. And the other is for those patients who recur with effusion after initial thoracocentesis. Other investigations include doing a routine bronchoscopy to rule out if there are any endobronchial lesions, and because malignant mesothelioma does not produce endobronchial lesions, so if there are presence of endobronchial lesions, then the diagnosis of malignant mesothelioma may be wrong, and then we have to further evaluate whether this is another lesion or whether it might be an adenocarcinoma of the lung or not. Similarly, we can do an endoscopic ultrasound or an EVAS to look at the mediastinal part of things. If we cannot take a biopsy from the from the chest wall parietal pleura, the mediastinal pleura might have some nodules, and biopsy from these sites can be done using the EVAS or EVS. So this is a picture of rats showing the mesothelioma. This is the pleural plaque, and this is the mesothelioma. So there was one study by Grossner et al. In 1999, and they found that rats provided adequate tissue for histological diagnosis when other methods such as closed pleural biopsy failed. So, as I said previously, ultrasound guided percutaneous needle biopsy has a high sensitivity of 83% and 100% specificity for diagnosing mesothelioma. So, this was a recent study where they evaluated 18 patients for diagnosis of malignant mesothelioma using ultrasound guided percutaneous pleural biopsy, and they found that similarly 83% of the patients could be diagnosed with ultrasound guided percutaneous needle biopsy. So nowadays, before VATS, at least one try of ultrasound guided biopsy for diagnosis of malignant mesothelioma should be given, as every intervention into the pleural space will lead to needle tracking and seeding of the tract. So a VATS biopsy may lead to multiple seeding sites, whereas a pleural biopsy using USC guided needle can may lead to only a single seeding site. So after receiving the tissue, we have to do the histological diagnosis, and there are three histological subtypes. The epithelioid is the most common, comprising 60 to 70% of cases, and there is a sarcomatoid variety comprising 10% cases, and the mixed variety with either an epithelioid dominant or a sarcomatoid dominant comprising 20 to 30% cases. These are the pictures. This is the epithelioid variety, where we can see that the tubular structures can be seen along with the malignant mesothelial cells. Here, this is the sarcomatoid type. This is the sarcomatoid type, where the stroma has been involved with the malignant cells. Here we can see the mixed type. Here this is the stromal invasion, and this is the epithelioid component. This is the picture of a high-grade pleural sarcoma, which is different from the mesothelioma, but mimics the mesothelioma. So how do we differentiate the malignant mesothelioma from these other diseases? As epithelioid variant may be confused with metastatic adenocarcinoma. Many cases we have seen in our clinic when the patients are diagnosed histologically as malignant mesothelioma, but when we send the immunohistochemistry, they come out as metastatic adenocarcinoma. Similarly, sarcomatoid variant may be confused with some types of metastatic sarcoma. So the International Mesothelioma Interest Group recommends using a panel of at least 2 immunoreactive and 2 non-immunoreactive markers according to the disease that we are suspecting to establish the diagnosis of mesothelioma. Pankeratin is a stain that stains all epithelioid mesothelioma and almost all of the sarcomatoid mesothelioma. Similarly, WT1 and calretinine are the mesothelial markers and are always present in patients with malignant mesothelioma. These are the positive markers, and negative markers are could be if if it is a epithelial variant, then TTF1 and others to rule out adenocarcinoma. Similarly, uh, use of estrogen receptors to rule out breast adenocarcinoma can be done. And if it is very difficult to differentiate even with these markers, then use of BAP1 and CDKN2A to differentiate a typical mesothelial proliferation from a malignant pleural mesothelioma can be done. So coming to differential diagnosis, malignant mesothelioma may be confused with benign conditions such as chronic organizing uh, empyema and but histologically, there will be no stromal invasion in these benign conditions. In malignant conditions, again, as I said previously, certain sarcomas may present as a sarcomatoid mesothelioma, and this is very hard to differentiate even in histology and immunohistochemistry should be utilized to differentiate this. Similarly, pleural metastasis of peripheral lung adenocarcinomas and metastasis from solid tumors such as breast, stomach, ovary, prostate, kidney may mimic the epithelioid mesothelioma. And again, here also immunohistochemistry is useful to differentiating these chemistries. So coming to staging, the ninth edition of the AJCC staging system has been out, and so according to this TNM staging, T1 is tumor limited to the ipsilateral pleura with P sum. Here P sum is the cumulative sum of pleural thickening at three places in the as seen from the axial pictures. The three places are divided by two lines. One is uh, I forgot the lines, but according anatomically, we divide the chest into three spaces, and we measure the pleural thickness in each of these places, and accordingly we get the P sum, and if P sum is less than 12 with no involvement of the fissure, then it is T1, and if the P sum is less than 12 with involvement of either the fissure or mediastinal fat invasion or a solitary chest wall soft tissue invasion, then it is T2. But if it is P sum is more than 12 but less than 30 mm also, it is T2. Similarly for T3, if P sum is more than 30 mm, then it is the stage T3. Whereas for T4, if there is chest wall bone invasion, if the mediastinal organs are involved, if there is diffuse chest wall invasion as compared to only a single site, and if there is direct tumor extension through the diaphragm or the pericardium, if there is direct extension into the contralateral pleura and presence of malignant pericardial effusion are clinical T4 lesions. Coming to N1, involvement of the ipsilateral intrathoracic lymph nodes, that could be the bronchopulmonary, hilar, subcarinal, paratracheal, the aortopulmonary, paraesophageal, peridiaphragmatic, pericardial fat pad, intercostal, and internal mammary. That is all the lymph nodes in the ipsilateral side of the chest. If they are involved, they are N1. And if the either the ipsilateral or contralateral supraclavicular lymph node or the contralateral intrathoracic lymph nodes are involved, then that is N2. For M, if there is presence of distant metastasis, then it is M1. If there is no, then that is M0. Accordingly, the TNM in 9th edition has been divided into stage 1, 2, 3, and 4. So, according to the previous staging systems, we can see that overall there is a poor survival of mesothelioma for any stage. Increasing stage shows poorer prognosis. stable patients. So although surgery has a limited role in management of malignant pleural mesothelioma, it should be mentioned it is performed in selected patients with early stage epithelioid histology and good performance status. Unfortunately, in patients with biphasic or sarcomatoid histology, surgery has shown to have poorer prognosis as compared to patients who are only treated with chemotherapy. So there are main two types of surgeries that can be done in patients with the MPM. One is the extrapleural pneumonectomy, where en bloc resection of the lung, pleura, diaphragm, pericardium is done after along with reconstruction of the pericardium and the diaphragm. This has a higher morbidity, but in the long term may offer survival benefit in some cases. The other is a pleurectomy decortication. This is a lung sparing surgery, and it is less morbid than extrapleural pneumonectomy, but the patient has a prolonged hospital stay because of prolonged air leak in this case as compared to extrapleural pneumonectomy. But it has a less mortality rate. And sometimes pleurectomy decortication may also include resection, either partial or complete resection of the diaphragm or the pericardium. And these surgeries should be performed only in stage 1 to 3A of malignant mesothelioma, in again emphasizing the epithelioid histology and with a very good performance status in a patient who is willing to accept the risk of surgery. And the aim should be for macroscopic complete resection, that is either a R0 or R1 resection. If R2 resection, if it seems intraoperatively that we cannot achieve an R0 or R1 resection, then it is probably better to abandon the surgery at that time instead of proceeding with this type of morbidity. So coming to extrapleural pneumonectomy, this was first attempted for curative dissection of MPM by Butchart in 1976, and he performed the surgery through a posterolateral thoracotomy and entailed an extrapleural dissection to include the final specimen, the pleura, lung, ipsilateral diaphragm, and the pericardium. And the diaphragm and pericardium were reconstructed using mesh. Nowadays, the Gore-Tex mesh is used to reconstruct these structures. So this comes as the final specimen, where you can see the pericardium, ipsilateral entire pericardium, the diaphragm, the entire parietal pleura, along with the lung has been removed. So this is the picture of the extra pleurectomy decortication. The entire pleura is mobilized, then the parietal pleura is incised, and also the visceral pleura should be mobilized over the underlying lung parenchyma. So, in summary, these are the main surgical procedures for patients undergoing malignant pleural mesothelioma. Extrapleural pneumonectomy and extended pleurectomy or decortication and pleurectomy decortications. These entail achievement of the R0 or R1 resection, and further down, either a partial pleurectomy or a pleurodesis may only achieve palliation. So we can see survival, the more complex surgeries that can be done can lead to a higher survival. And but this also comes with a caveat, because some studies they have shown that surgery has not been as effective as only chemotherapy in management of malignant pleural mesothelioma. So again, comparing extrapleural pneumonectomy with pleurectomy decortications, multiple studies have shown varying degrees of survival, and overall, while comparing them, they are almost similar. Some studies have shown survival better for extrapleural pneumonectomy, whereas other studies have shown survival is better for pleurectomy decortication. So this was the MAS study that was completed in 2011. This study aimed to compare if there is any benefit of extrapleural pneumonectomy in addition to chemotherapy in patients with malignant pleural mesothelioma. Unfortunately, this study did not show any benefit of EPP as compared to only chemotherapy in patients with this disease. And this group again, they did a second trial, the MARS 2 trial, where they compared benefit of where there was any benefit of pleurectomy decortication with chemotherapy with respect to chemotherapy alone, and this was published in 2024. And again, unfortunately, even only pleurectomy decortication did not show any advantage compared to chemotherapy alone. However, there are many flaws in these studies, as the inclusion criteria were not adequate. So again, there is controversy. Even though these trials have shown that there is no benefit of surgery, there is still controversy, and many other retrospective studies have shown benefit of surgery compared to chemotherapy alone. So for the most part, malignant mesothelioma is managed with chemotherapy. And these include for those with non-epithelial histology, advanced stage, or poor performance status who are unable to undergo surgery, or in the adjuvant setting after surgery. After 2009, many studies have shown that pemetrexed has a advantage as a survival advantage in the management of malignant pleural mesothelioma, and now the standard combination is a platinum agent, either cisplatin or carboplatin with pemetrexed for chemotherapy. And in fit patients, the anti-VEGF agent bevacizumab is added for further benefit. This is a survival curve for of the evolution of management of stage 4 patients with this disease. So in this first picture, the dark line is the one where the patients were given cisplatin with pemetrexed, whereas the dotted line is the one where the patients were only given cisplatin, and we can see some survival benefit of addition of pemetrexed to the cisplatin. Similarly, this is the study where addition of bevacizumab showed the slight survival advantage to patients only receiving chemotherapy. And this picture shows that there is some benefit of adding immunotherapy agents compared to only chemotherapy, and that is nivolumab plus ipilimumab has a greater survival compared to chemotherapy alone in patients with this stage 4 NPM. And this was the checkmate 743 trial. So there is, although there is some evolution of treatment therapies in the management of malignant pleural mesothelioma, the survival is still dismal. We can see there is rapid increase in mortality over only a few months in all of these cases. So radiation is also one modality that can be added, and if the patient have localized mesothelioma, or if there is suspicion that there is inadequate resection within surgery, adjuvant radiation has a role for local control. As most of the mesothelioma they recur locally as compared to systemically after surgery, the adjuvant radiation has also an important role in the therapy of these patients, and trimodality therapy has also shown some benefit in patients. Finally, newer therapies that are emerging in the management of malignant pleural mesothelioma include the molecular and targeted therapy, as most of the mesothelioma are involved by the BAP1 mutations, the CDK2 deletions, and NF2 loss. So there are ongoing trials that are evaluating these agents. Similarly, mesothelin is overexpressed in malignant mesothelioma, and many agents that target mesothelin are also currently under investigation. So with this, I'd like to conclude my presentation. And
thank you, Dr. Ashish. Key questions पहले हम उठा लेते. But I think most important thing maybe you people have never seen the data. He said that in 85 patients that we did the breast biopsy here in ourselves, we have only one confirmed by ISC. So far, the global cones saying the 32nd place of the malignancy.
32nd place.
I still doubt that was proven by the ISC or not. It could be simply the histopathological examination, which is quite rude data. I mean, that will confirm that this is the metastatic adenocarcinoma of all the mesothelioma. I still think that mesothelioma is very uncommon in our country because we do not have the exposure to the asbestos. So, first for those residents who have come from CMC, there is